Well, without further ado, hello and welcome everybody to Maternal and Infant Health Canada's educational webinar series. Today, we are joined by Dr. Kate Levett, who will be discussing complementary therapies for labor and birth. For those who are new, a little bit about Maternal and Infant Health Canada. We are a global health collaborative working to improve the health of women and children around the world while seeking equity-driven solutions to a more sustainable world. This is achieved through our education, research, and innovation pillars. We are made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world. We have also recently joined forces with the Global Women's Health Network, alumni of the Harvard TACAME program in the International Health Department, and they will be co-sponsoring these webinars moving forward. So we really want to kind of welcome them, and we really look forward to their involvement. We've also recently updated our social media, and we've had some wonderful new additions to our team. So we now have updated our social media, our email newsletter accounts. So if you would like to keep up with everything that is happening at MIHCan, you have a lot of different ways. I am going to actually, before I even tell you them, I'm going to put them all in the chat box. So if you would like first to be part of either our WhatsApp, because I know a lot of the people in India and Nepal prefer WhatsApp, so you can email mycancares@gmail.com and let us know your number, and we will add you to our WhatsApp group. We also have a Facebook page, which is in the chat box. There is a link there also to our recorded webinars. As Dr. Schroff had mentioned, we have 6 webinars that we do a year, and all of them, or most of them, get recorded. So if you'd like to go back and see some of the previous lectures we've done, you're welcome to go, and that's all in the chat box. We also now have just started a LinkedIn page, so you are welcome to join us and connect with us through LinkedIn as well. We'd like to keep you all informed of our webinars in the future. So please connect with us, and that way you can stay up to date with all of the future webinars that we'll be having. And if you'd like to contribute in another way, you're also welcome to reach out for that. Now, as with all of our public webinars, I must add the following disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. If you have questions during this webinar, please write them in the comment box at the either bottom or side of your screen in our chat area. And what we'll do is we'll capture those questions and then ask them at the end of the lecture. Discussion is a really key component of these lectures. We're really about building community and everybody, coming together with their ideas. So please don't be shy and put down the questions that you have. As usual, I am your moderator, Dr. Emily Solomons. I'm a doctor of traditional Chinese medicine and a Maternal Infant Health Canada team lead. I am zooming in from the ancestral and unceded lands of the Coast Salish people, also known as Vancouver, BC. We also have Dr. Farah Schroff, who is the founder and lead of Maternal Infant Health Canada, and a previous TACAME fellow at Harvard University. So we really appreciate her tuning in today. And then, of course, our distinguished speaker today is Dr. Levett. Dr. Levett has been working in health education, acupuncture practice, and medical research for over 20 years. She's a specialist in acupuncture, research methods, and education. She has a bachelor's of education, a master's of public health and research in epidemiology from the Univ.Sydney, an Advanced Diploma in Applied Sciences and Acupuncture, and bringing these skills together in her PhD from the NICM Research Institute at Western Sydney University. So without further ado, I'd love to pass this now on to Dr. Kate Levett, and she will share her presentation on complementary therapies for labor and birth.
Thank you very much, Emily. I'm so pleased to be here with you all today. And I also want to encourage any questions that you've got. I'm not able to see the chat that clearly, so if you want to interrupt me, please, Emily, then do so. This has been geared towards maybe a bit more researchy. So if you're wanting more information about contents or the complementary therapies or the way we've applied things, then please stop me, and I'm more than happy to refocus things on the actual therapies as opposed to the research methods. But those of you who are interested in collaborating in research in this particular topic, also be very pleased to talk to anyone who's interested in implementing any of these projects or programs in their own research studies. And so I just wanted to thank a few people. The work that I'm doing is funded by Australia's NICM and MRC, which is the National Health and Medical Research Council, and I'm currently funded as an early career fellow at the University of Notre Dame in Australia in our School of Medicine. But I'm also affiliated with the NICM Health Research Institute at Western Sydney Uni, Centre for Midwifery, Child and Family Health at UTS in Sydney, and pleased to be collaborating with MIH Canada, UBC Canada, and with Healthy Seminars. Thank you for inviting me to come and speak today. I'm going to talk a little bit today about an original study that I did for my PhD, which we called the Complete Birth Study, and it's been renamed 100 times. So it was called Complete Birth then. You might find us now called Birth Course. And it was a childbirth education program which used integrative medicine, 5 or 6 different integrative medicine techniques for the management of physiological labour. And we looked at outcomes, medical outcomes for women and babies. We looked at the experiences of this program for women and partners, and then also did focus groups with midwives, and we did an economic analysis. And I'll briefly take you through that study. But since then, the project that I'm currently working on, the EDUCATE collaboration, which is a protocol for how we would conduct a prospective meta-analysis. And I know lots of you know about retrospective meta-analyses, which is like the Cochrane systematic reviews or other systematic reviews, where you collect data and look back and put it together. This is a way to collaborate on projects where you collectively produce projects that collect the same outcome data and look forward. So I'm interested to hear what you think about methods, about how this method might be applied to other areas of maternal health and other areas of potentially Chinese medicine. Our EDUCATE collaborators come from all over the world, particularly from Australia, the UK, and we have some collaborators from Denmark as well. Where the current fellowship grant is this particular grant for the EDUCATE collaboration. And just a little bit about prospective meta-analyses. So it's one of the methods that the Cochrane group, so if you're interested in this at all, the Cochrane group has a methods group for prospective meta-analyses, and that's headed up by Lisa Askey, who is at the University of Sydney. And a PMA is a meta-analysis, so it's usually randomised controlled trials, but you can also put other forms of trials in there, like cohort studies. There's methods for that. And these studies are identified, evaluated, and determined to be eligible before results are known. And we all agree on outcome measures and collection of data that is common so that we can put those things together, which makes for a much more robust kind of study. So with regular systematic reviews, the primary evidence, and we've all seen in Chinese medicine where they say the Cochrane systematic reviews, one of the risks is that the evidence was low quality. And that's for a variety of different reasons that the evidence was low quality. But if you're including lots of low quality studies in your group, you're pulling up low quality evidence and synthesizing that to try and make sense of a result that doesn't always, it carries some biases with it, and those biases just get carried up and up and up. And so you can compound the problems of primary studies. There's been lots of conflicts identified, sponsorship, et cetera, et cetera. And so with systematic reviews, while it is our best level of evidence, there are some problems that go with it, which can make it somewhat misleading, which is why prospective meta-analyses are gaining traction in the research world. So the current project around the Educate collaboration, we're looking to evaluate the effectiveness and cost effectiveness, as well as the experiences of women in implementing comprehensive childbirth education programs into routine care. And if we get a large sample size, we're going to be able to explore what are the facilitators and barriers that may influence this implementation. How does this apply to diverse populations, different hospital settings, different countries, and different risk levels for women giving birth. Our primary objective is to look at the effectiveness of these comprehensive programs, plus usual care versus usual care alone, in reducing rates of caesarean section. And mainly it's for first-time women. As first-time caesarean section, the index caesarean section is what drives increasing rates of caesarean section around the world. And although in our study, it's the women who are multiparous are eligible for participation, the primary analysis will be conducted only on those first-time mothers. But other secondary analyses will be conducted on other data and other women. So why are we doing this? Why do we care about caesarean section rates or women giving birth or what's happening with maternal health? And we know across the world that giving birth is the commonest acute overnight hospital admission. And it costs a lot of money for the health systems for women to be in hospital. Our intervention rates currently are critically high, and that has been highlighted by the WHO, by all maternal health reviews across the world. And it consumes a really large proportion of our health budget. When we look at in Australia and Canada, there's around 350,000 women who give birth each year, and in the UK up to 650,000 who give birth each year, and then much higher again in the United States. 98% of those women use maternity care services, and whether it's public or private or independent midwives or whoever it is, they will mostly be in our public health system. And in Australia, more than 75% of women give birth in the public system, and that constitutes more than 1 million patient days in hospital per annum. So if we were looking at developing some cost-effective programs, we would really be wanting to target unnecessary medical interventions, like those that are seen to be above what is needed for the safe care of women and babies to be born to those women, without overdoing medical interventions which actually have an adverse effect on women and babies. There's a sweet spot for caesarean sections of around 10 to 15%, and anything below 10% or above 15%, we see an increase in adverse events for women and babies. Currently, the caesarean section rate in Australia is 35%, and we are seeing a lot of adverse events. And there's lots of drivers for those high caesarean sections, which we could talk on all day long. But suffice it to say that there is a requirement for caesarean section. 10 to 15% of women really need a caesarean section or other medical interventions, but not 35%. And so we're looking at how we can help women understand and support physiological birth so that those medical interventions don't become necessary. So we want to also assist in the development and implementation of novel models of care. And that implementation is a really important part of that, because we see that there are big gaps in childbirth education and the way that that is implemented into routine care. And what is learned in childbirth education isn't always standardised, it isn't always implemented, and it's not always respected. It's seen largely in Australia as a sideline activity that is not, what is taught in childbirth education is not integrated into routine care when women actually present to give birth. And I can't talk for other countries, but I know that that's the case in Australia and also in New Zealand, I would say. So as a bit of a background, we see that rates of medical interventions are skyrocketing. And in particular, we see more than 50% of women in Australia are being induced, their labours are being induced, and only some of them are for medical reasons. We've currently have some nationwide surveys about women's experiences of medical care, but particularly during the COVID-19 pandemic, and hopefully those publications will be out soon. But women's experiences of increased medical interventions during COVID, in particular, induction of labour for no medical reasons, has increased the amount of trauma experienced by women and by healthcare practitioners in the hospital system. These medical interventions are seen as routine. It's a way to manage women. If we get them in, we induce them, we pump them through the system, we get them out, and practitioners see that as a way of managing women in the labour wards. And it isn't always the best way to manage things, and it increases intervention rates. We've seen the WHO Lancet series, where excessive use of caesarean section has been identified as a really key an emerging outcome that needs to be addressed. And in reviews of maternity services across the United States, Canada, England, Australia, New Zealand, we see that reviews of maternity services repeatedly call for reductions to these caesarean section rates, but nobody talks about how we're going to do that. Well, they're talking about it, it's just not being implemented. So in terms of childbirth education, what do we know so far? There has been a systematic review on the effects of childbirth education, a Cochrane systematic review that was last updated in 2007. And I hear that a new update is underway, but it's not yet been published. So at that time, in 2007, the conclusion of that Cochrane systematic review by Gagnon and colleagues said the effects of general antenatal education for childbirth or parenthood remain largely unknown. We were unable to determine what the outcomes were. More recently, there's been a non-Cochrane systematic review by Hong and colleagues, and they found that antenatal education does have a role in reducing maternal stress. So we've seen that in quite a few studies, improving self-efficacy, that's been well documented as well. And then the newer outcome of lowering the caesarean section rate and decreasing the use of epidural analgesia and anaesthesia has largely come from the outcomes of my study. So the study has created a tipping point in the data. So one study, if it's large enough, can create a tipping point in the data, and then the outcome of a systematic review will be changed. So we're seeing that does come through in these systematic reviews. So the question is, how do we then standardise, implement, get it out there, and get people interested in how they can integrate childbirth education? So in Australia, we have a group called CAPIA, and that's the Childbirth and Parenting Education Association. And they have developed a whole list of competency standards. And those standards have no requirement for implementation or evaluation. So they're written, but nobody's required to do anything with them. There is a lack of evaluation or any kind of examination into childbirth education as to outcomes, effectiveness. What we do see a lot of is satisfaction scores. So women are satisfied and it's well attended to come to childbirth education, but what outcomes are we actually aiming for? What are we trying to do with our childbirth education? What's the purpose of it? It once was implemented as a public health measure for implementing and disseminating information about healthy eating, smoking cessation, drinking alcohol cessation, and also on the back of the twilight drugs, where women were in the 50s and 60s given a cocktail of drugs, including salcolpamine, which caused all sorts of trouble. And there was an advent of modern childbirth education came after that to try and give women a voice in how to manage their labour and birth without being given all these terrible drugs that they then didn't remember, and they were, had a terrible effect. But my main concern now is the integration of this evidence. What do we do with it? How do we get this into routine care? How do we as practitioners and healthcare workers support evidence-based practices to be able to transform childbirth education, but also integrate it into systems? In Australia, in New South Wales, which is the most populous state in Australia, the Department of Health has a pregnancy care guidelines, which states that antenatal education aims to develop social networks for young families, which is great, in your local districts. You're meeting up with other families. That social support's really important. They want to influence health behaviours. So as I said before, drinking, eating, smoking, all those sorts of things, those common public health intervention measures. And they want to have measures to reduce perinatal morbidity and mortality. And how do they propose to do that? And one of those things is to prepare women and partners for childbirth by building women's confidence in their ability to labour and give birth, preparing women for the pain of labour, and supporting their ability to give birth without pain relief. And why is that important? Why is giving birth without pain relief and preparing women for labour, normal physiological labour, important? Why would we want to do that when, well, if you can take the pain away, well, why won't you just do that? Why do we see that as important, that women's physiology is maintained for best birth outcomes? And because we know that pain relief as an intervention often comes on the back of an induced labour. Once you're induced, you're much more likely to have pain relief. And once pain relief is given, often the body stops actually recognising that they're in labour. And then labour slows down and then more interventions are needed. So it's this cascade of interventions that's seen on the back of induction and some pain relief methods. That's the important bit. And that's what we're wanting to support women to be able to use physiological techniques to support the maintenance of labour, kind of regardless of what else happens. So even if women are induced, how do we help to support them with techniques to be able to keep labour on track and in a way that supports women and babies? So in classes, we've seen that there's a shift in focus from parent education rather than birth preparation. So it's lots about parent education, which is, also very important. You've got to take that baby home and be responsible for it for a long time. So important to have some parent ed. There's a message that's flowed through in classes about, this is just a day in the life and, you just get through it. That's not the important bit. But we see over 50% of women in our survey during the pandemic, over 50% of women report having some kind of postnatal trauma following their birth. Over 50%. Like, that's a big thing for women to have to go home and deal with, in experiencing symptoms of post-traumatic stress and trauma in their lives. And then, how does the system manage that? And how do we support those women? So if we can work out a way that we can support women beforehand and support them in the way that's going to help them the most, then we might be avoiding problems down the track. We see that evidence-based practices and integrative medicine techniques are not well integrated into intrapartum care. Classes are seen as a bit of an induction to hospital policies and procedures. You're going to come in on this date, then you're going to have that thing happen to you, then you're going to get an admission trace, and then we'll see if this is okay, and then we'll decide if we're going to let you do whatever it is that you're after. They adjust couples' expectations to probable interventions. I've heard of lots of classes being taken up with having mock cesareans so that people won't be frightened when they get into the operating theatres, rather than having that as a maybe, that's something that would happen, and the focus being on how to support women rather than prepare them for almost the inevitable interventions that are going to happen. And then there's a normalisation of medical management, of women being monitored continuously, of being hooked up to catheters, by having drips in. When I attended a program in the United States, I was kind of surprised to see every single person had Syntocin. What do you call it? Pitocin? Syntocin? What's it called? Pitocin. So called Syntocin here and Pitocin in the States. Everyone had some hooked up, and everybody was attached to a machine and nobody could get out of the bed. It was, it's the level of medical management is really disabling women's physiology to be able to be pursued in a normal way. Women seem unprepared for their birth. They're fearful, lacking resources, and feel traumatised when it's finished. This medical management's normalised. Caesarean section is well and truly emerging as an important maternal outcome, and they're seeing long-term consequences of that. We're doing very little to prepare women for normal birth, and it's seen as a lot of it's seen as just kind of woo-woo that people are going to be preparing for normal birth. Since the 2017 ACOG recommendations, which was a really like a bright shining light, where they've talked about in the intrapartum period, instead of all of these things that seem routine, admitted early to facilities, using continuous EFM, labouring without continuous support, using IV, no fluids, breaking membranes, lying in bed, using epidurals routinely, pushing while you're on your back, pushing with care provider direction, following coaching by staff, et cetera, and they've changed those recommendations. And this does reflect the evidence. Waiting for active labour, staying at home and waiting for active labour, which is now being seen as being around 6 centimetres rather than 4. In Australia, once you're in the hospitals, you've got 12 hours, you're on the clock and you've got 12 hours to give birth. And once that kind of gets near, people start pushing for interventions. So encouraging women to stay home for as long as possible so that they let their bodies, allowing that normal physiology to unfold. Listening to the baby's heartbeat with handheld Dopplers, continuous support, being up and moving around, drug-free measures, giving birth in the most comfortable position, et cetera, et cetera. So these things, that was a big, big push from the ACOG to be able to release that, and that's been a really good baseline document to be able to produce in support of these kind of measures. So back in I don't even know how long it was ago now, the results of this study was published in 2016, but we were working on this from 2011 to 2015 while I was doing my PhD. We had a background course called SheBurst that we were using as the basis, and then we developed that using only the evidence-based medicine, only the evidence-based techniques, and we only had evidence-based content, and we changed that into a course called Complete Birth. And it was a randomised controlled trial, intervention plus usual care versus usual care alone. And it was a 2-day workshop for women and partners, and the partner could be anyone, and the partner could be more than one person. We included first-time women, low risk, not in continuity of care, and not in a continuity of care model because they have outcomes that are different from the regular care model. So we just didn't want to dilute or obscure the outcomes. The interventions talked about, or the program course talked about, where their knowledge base was around the normal physiology of birth, the hormones, principles, how to support those normal hormones of labour. Giving partners direct information about supportive care techniques. How can partners be of use? What can they do? How do they do it? What techniques would they use? What works between the couple or the group who are there? How do they talk to each other about it? How do you give signals, et cetera, et cetera? The particular tools that we introduced were acupressure point selection, upright and active postures and positions to labour and birth in, guided visualizations. We had 4 separate visualizations, 4 separate breathing techniques, and 2 different massage techniques that we introduced to people. And someone at the Family Way has put together this little infographic which shows you what we used in the study in a nice way to just help to, as a little cheat sheet, which I'm happy to share with anyone who would like it. These are the results here, which I'll just try to briefly go through. We published the randomised controlled trial in the BMJ Open, which is open access, so anyone can look at that. We published the cost analysis also in the BMJ Opens. Again, anyone can look at that. And then the complementary therapies, the experiences of women, partners and midwives, from the focus group and in-depth interviews we've published in the journal Midwifery. Also happy to share, that's not open access, but happy to share. So what did we find? We found that there was a significant reduction in epidural analgesia, which seemed to be the driving force behind the other outcomes. 68%, you say, that's a high level for the control group. And I think this is one of the things that's important. 68% of the control group had an epidural, and I think that aligns with other studies that have recruited women who are anxious. So women who score highly on the anxiety scales tend to be more likely to have epidurals. And it's possible that we implemented or we recruited women who were anxious and a particular demographic, which is why now we're interested in differentiating or diversifying the population that we're looking at to see does this hold in other populations. So 68% in the study group and down to 23% in the control group. Increased rates of normal vaginal birth from 68% to 40, where it was 47%. So the less than half had a normal vaginal birth in the control group. We saw reduced rates of augmentation. We saw now significantly 32% epidural, cesarean section rate, which is the about the national average at the time, down to 18%, which is nearing the WHO recommendations. We saw a reduction in instrumental birth, but there weren't really enough people in the groups to be able to see, but it had a trend for significance. We saw a significant reduction in requirement for resuscitation of the newborn. And that's really important. Fewer babies required resuscitation after they were born. I think that's really something to hold on to. Spontaneous onset of labour. There wasn't a difference in those who were induced. In fact, there were a higher amount slightly in the treatment group who were induced in their labours. And that could have been through a variety of mechanisms of induction. We saw, which we weren't really looking at, we saw no difference in rates of pethidine. And actually, I didn't realise that the levels of pethidine use was still so high in the hospitals that we were in, and we hadn't really thought about that beforehand, about talking about pethidine and its use in labour. Nitrous, which is really widely used in Australia. I'm not sure about Canada. Nitrous is well used, but not well used in the United States. There was a reduction nearing significance. Perineal trauma was reduced, but major perineal trauma there was no difference. But first and second degree tears, there was a reduction. Postpartum hemorrhage, no difference. So in safety outcomes, postpartum hemorrhage, APGAR scores, and admission to NICU or special care nursery, no differences. So we can see the safety outcomes are not, there's no change in those safety outcomes, which is promising that we're not, increasing any problems. In our qualitative interviews, we found that the overarching theme was around making sense of labour. Women and partners said that through the process of gaining understanding about what the purpose of labour was, about the body's purpose, body's capacities, they became motivated to use tools and techniques to support normal birth. And they felt that they had a toolkit, so lots of different options and things that they could use at different times during the labour. We found that on average they used between 3 and 4 different techniques during their labour, and it gave them confidence for managing the labour and a sense of control. All of the partners, when we interviewed partners, 100% of partners said that acupressure was their most used and favourite tool. Women and partners came to see medicine as a backup. So while they were really grateful that they were in a hospital and that they were had best medical care that they could have, they didn't see it as their only option, that they had other things to use. And if something actually went wrong, then they had medicine as a backup, but not as the only method for managing their labour. And that, I think, is the big difference. You've still got it if you need it, but you don't need to use it just to manage routine labour. Midwives said that they found that they followed the women in labour. So that meaning that when the women initiated things, they followed them and supported them. If they wanted medical interventions, they supported that. If they wanted natural support, they supported that. And they said once they're in labour, it's too late to educate them. Women need to know what they're doing before they get there. We don't have time to educate them in antenatal visits. So that's important. They need them to be educated beforehand. They don't have time to do it. They think antenatal education is important. They need to know what they're doing when they get there. Women who know what they're doing are easier to work with. So they've got some tools and techniques. They're easier to work with because they can make suggestions and support them and help them out. And then I'll just quickly go through the cost analysis. We use the Australian Refined Diagnostic Related Group Codes, which are internationally translatable. So when we're combining studies, you can use these codes are relevant, just called something different in the United Kingdom, Canada, New Zealand, Australia. They all have similar kinds of codes, and other countries too. We based it on the highest level of intervention during labour. So if a woman was induced, then she had an epidural, then she tried instrumental birth, but that wasn't successful. And then she had a cesarean section. She was coded as cesarean section. So not coded as all the things that went along on the way. Highest level of intervention. And then we grouped the hospital admissions. So the ARDRG codes group hospital admissions of the same clinical type so that you can cost the interventions. And we found overall women who were in the study group, they saved an average of $808 per woman per birth over the study with the cost of about $150 for the program. So an overall saving of about $667. And if you translate that to 300,000 women per year, that's a lot of money. Mainly, it came from this reduction in caesarean section. So this group C here, that's where we saw the main cost saving. We saw a slight increase in instrumental vaginal birth with a reduction in caesarean section, but also a significant increase in the normal vaginal birth. And the caesarean section over here, this is pre-planned caesarean section. So we've seen significant reductions in caesarean section, epidural, perineal trauma, newborn resuscitation rates, and a shorter second stage of labour, which I didn't include before. So that's the pushing stage. Qualitative themes, making sense of labour, medicine as backup, having a toolkit, and a saving of around $650. So we can see that trial supports normal birth, integrated value of integrated childbirth education, saves money, reduces caesarean section, etc. So what are we doing now? How do we roll this out? How do we look at more diverse populations? So currently we're looking at this individual participant data, prospective meta-analysis. And we're doing this prospective meta-analysis of comprehensive childbirth education, which we want to assess on a larger scale, more diverse populations and settings. So we're interested in different countries, different women, different risk profiles. The study that was done in Australia was in an area that had relatively higher income, socioeconomic status, and background levels of education. So we want to look at diversity. How does that inform broader implementation, and to what extent, depending on who, when, what, how, where? We want to assess the factors that modify effectiveness of childbirth education. Is it modified if they're engaged in different models of care? What are the different demographics and insurance status? What's the impact of that? We see in Australia those who are privately insured are much more likely to have intervention rates than those who are publicly insured or not insured, because intervention rates amongst obstetricians are going to be higher. Even when you've got the background, the referent woman is the same across a public-private system, we see intervention rates higher in the private system. What's the difference depending on parity, obstetric risk, socioeconomic status, cultural background, and comorbid conditions? We need international and national input, and that's how we're developed. That's the prospective meta-analysis is based on those on input from different trials and different sources. When we first started this, we had some randomised controlled trials, and we had 5 individual trials that were planned. One in New South Wales, South Australia, Victoria, and UK. Currently, we've got 2 in New South Wales, 1 completed in South Australia, and 1 in planning in the UK. We've got online in COVID. We've now developed an online program, and we're about to go back to in-person programs. So we're looking at those factors as well. Who knew before COVID? So looking at online education versus in-person education as well. And we want to look at qualitative and also cost analyses. The primary question is around the addition of comprehensive multi-component antenatal education birth preparation program to reduce caesarean section rates in nulliparous women compared to standard hospital care. So in addition to standard hospital care. And then what do participant intervention components or hospital characteristics modify the effectiveness? So we know it's an individual participant data prospective meta-analysis with the Educate collaboration. I'll just whiz through this a little bit. What do we want to include? So we want to include knowledge and understanding. So that's about providing education about normal physiology. How do our hormones work? How does physiology work? What do women and partners know and understand about how they implement that? Encouraging a positive mindset. So focusing on positive psychological aspects of women's ability and capacities for normal birth, and encouraging those positive psychological focuses. And then introducing tools and techniques. So how can we provide a range of things for women and partners to try, and also for midwives or whoever the care providers are to try? These can be manual therapies like yoga, acupressure, and massage, relaxation techniques like breathing and visualization. There can be a range of positions, movement, upright, side-lying, yoga postures, comfort positions, enabling women to listen to and respond to their bodily cues. And any other evidence-based techniques that are deemed to be appropriate for inclusion by whoever the clinical trialist is. So this is not limited to these things, but so long as it's an evidence-based technique, that is included as a tools or technique. And we also want to address common interventions in the classes, common interventions and hospital procedures, because women need to know about those things as well. If this happens, this is what you might expect, and here's ways to manage it. So we've got prospective meta-analyses requirements and opportunities. So people who are in research, who are keen to contribute, who want to participate, who want to run their own trial of antenatal education or childbirth education, please join us and we will assist you. Even if you don't have a program and you want to run the birth course program, also happy to assist you in that way. If you've got a way to run a trial in your home place. So programs that are included include the three components: knowledge, education, and support and techniques. There's no requirement for the protocols to be identical. And in fact, having variety is good because we get to see different components and the way they contribute. We want to accommodate different group settings and practices. Identify is there a particular group for whom childbirth education is most beneficial? Who is it that really we need to focus on in these areas? People are able to define their own entry criteria, outcome measures, but we share the same core pre-specified protocol elements. There's an opportunity to develop standardised protocol in partnership with other trials, receive training in a program, but anyone who wants to run one of these trials retains their autonomy and responsibility for the conduct of the trial, and then working together about how we put all the data together at the end. If anyone's interested, we can run through any of these things, but overall, we're looking for a sample size of 2,500 women, which will have the capacity to detect a clinically important rate of 5% reduction in caesarean section. And when we were first looking at this, we were saying 30 to 25%. Caesarean section rates are up around 35% now. So we're looking at a 5% reduction with that sample size, which would still be clinically meaningful. And other things that we can talk about if you're interested. So the evidence-based therapies included so far: relaxation and guided visualization, acupressure, breathing or acupuncture, breathing, movement, yoga, labour, comfort positions, and different massage techniques. And there's a variety of massage techniques like tuina or acupressure massage, or other forms of massage that have got an evidence base behind them. The control group is usual care in whatever setting you're in. And then we've got an independent data analysis group at the University of Sydney at the Clinical Trial Centre, who we're collaborating with about data analysis. Primary outcome we know is caesarean section. But I'm going to stop sharing there because I would really love to hear any questions that you have, and I can see in the chat box. And I'll just might run through that. But anyone wants to jump on and talk, put on your cameras. I would really love to hear from you. Any feedback, anything that you'd like to know about the individual interventions. Most of the Cochrane systematic reviews that are up to date now, 2019, 20 and 21, on all of these methods. I've been an author on all of those Cochrane systematic reviews, so we can see where the evidence is. So ask away, handing over now.
Well, thank you so much, Dr. Levett. This is wonderful, and it's exciting that it's come to this point where you're really kind of growing this research and expanding. I want to say thank you to Healthy Seminars and Parisa for organizing this as well. And yes, so please start adding your comments in the chat section. If anyone wants to actually speak, you're welcome to raise your hand and then you can actually talk. I know we've got some comments by Susan Minish, who was a nurse midwife in a hospital. Has a acupuncture practice for fertility, pregnancy, and women's health. And she sees a lot of birth trauma and postpartum depression, and teaches doctors how to deliver babies and not look at birth with fear. It's very challenging, she says, because there's so much medicalization in birth. And she really feels that your information and presentation is wonderful and spot on. So well done. She's very passionate about the birth process and women's rights for a safe and normal physiological birth. So that was her comments, and maybe in a bit we'll have her in.
I think that's dead right too, to be talking about fear-based practice. That I see a lot of doctors, their defensive practice, they're up against litigation, and if they don't do the cesarean section, they can be sued. And if they do it, they can say, well, I did everything. So it's very defensive practice, and I think doctors are scared, and a lot of that fear. And if we've got time, I'll tell you about one of my PhD students, her project, which is super fascinating. But I think you're right, Susan.
So the first thing I want to know, though, is if people are interested to read more about the details of the therapies used, what is the best way for them to access this information?
So, well, in Australia, Cochrane reviews are available for everyone. That platform, is that the case elsewhere? Are you freely available to get Cochrane systematic reviews?
Yep.
So that's where most of the evidence kind of sits. I've got quite a few talks and things about that evidence base, about going into the details of that evidence base, and I would be happy to share slides with people if they're interested. But there's quite a lot of evidence, and I kept saying stuff about postnatal depression too. There's good evidence for acupuncture around postnatal depression as well, but also there's a study that we're doing at the moment called the First Baby Study, and it's really apparent that if we know, first up, those women who have low social support and are being induced, they're the two key factors, low social support and induction of labour. They are much, much more likely to experience postnatal trauma and postnatal depression. We can identify those women. We know who's being induced, and we know who's got low social support. So what can we do for those women to support them? I think there's lots we can do, and people just sort of bury their head in the sand about it.
Dr. Shroff, was there anything you wanted to contribute?
Yes, I wanted to just ask Dr. Renu if she wanted to talk a little bit about postpartum depression in Nepal, because you had made a comment, Dr. Renu, about how it's increasing. And I just wanted to ask you if given what Dr. Levett has been talking about, has there anything that you found in Nepal that has been helpful related to acupuncture or Ayurveda or any of the treatments that you are working on?
Yeah, and thank you, Dr. Shroff. And actually, thank you very much for connecting me with this wonderful webinar. Actually, I really appreciate it. And thank you, Dr. Levitt, that this was a wonderful presentation. It really kind of evoked several questions, and I think that I need some time to kind of process and then get back to you as well, because if that is possible at all, right? So yeah, I as a doctor, I practice and then in maternity hospital and all, now very much converting to women rights activists and doing a lot of public health work. So this is just my introduction, right? Insert. And now what I see, in Nepal, there is a lot of push in country like ours, I think everywhere that is true, very much push on institutional delivery, in order to save kind of maternal death. That's what we are being told, called, and then convinced. But what we started to see that with the increase of institutional delivery, postpartum depression is also increasing, because kind of this whole our traditional traditional knowledge, what you were sharing, we in our tradition we had that massage kind of and whole social support, kind of mother-in-law will be massaging, and then mother will be massaging, and then giving a lot of social support, and kind of during birth. But now that is being taken away. So postpartum, we see that, we very clearly see that, there is connection between that. And then OREC being an organization which started to work on reproductive health, now we are trying to bring that element also in and trying to find out how we can help now we are taking support from one of our naturopath, yoga doctor, we are trying to introduce. We really want to bring that one and then look how that will work. And it will be really good, if we can get some kind of collaboration from the academic side, so that we can really prove that one. So I just wanted to explore and then say that, okay, for now, the treatment, as Dr. Strofe has asked, treatment is only antidepressant tablets. So which I think that, okay, we need to push that away. So this is what I thought that, okay, it might be a very good idea, to look into this. And then we have started something. We have started barefoot gynecologist concept, and we are bringing this whole Ayurveda and the naturopathy in. We will see that, okay, how that will process. So thank you, Dr. Strofe, for asking me to come in and connecting me. And thank you, Dr. Levett, wonderful presentation. And then I will be really happy to get connected and then to talk more on this. Thank you.
I've popped my email address in the chat for you.
Okay, yes, and for people on the recording, if they can't see the chat, because sometimes they can't see the chat, it's Kate.Levett, so KATE.LEVETT at nd.edu.au. Thank you so much for that comment, Dr. Renu. I feel like you really hit so many key points that we're seeing all around the world where traditional practices were used, and they were used, it was just part of the culture, and they've all been taken away. And to be able to almost use research to be able to bring those back in and really reignite the traditional knowledge that has always been there and has always been so helpful. So it's wonderful to be able to kind of use this research to bring that back.
And if I could just say, and Dr. Renu, one of the things that's happening all around the world to reduce maternal mortality ostensibly, and this really happened in around 2015 when we were trying to reduce maternal deaths by 75% globally, was this push for 100% facilities births. And so we haven't heard the kind of things that you just said, that as facilities births increase, so does postpartum depression. So because a lot of us, myself included, said, is that really the only way that we're going to reduce maternal mortality? Because here in this part of the world, 20 or 30 years ago, we worked really hard with the legalization of midwifery to include safe home birth as a practice. And now we've got that legislated in Canada for women to give birth safely at home with transfer possibilities. So it seems really, really challenging that the rest of the world is pushing for a facilities birth as the only solution to reducing maternal mortality and not looking at some of the other problems. And because mental health is so stigmatized and so marginalized, people will clearly say, oh, well, postpartum depression, what does that matter? That's not a big problem. Let the baby live, let the mother live, let the mother have a little depression as long as she lives. So we really haven't gotten to the nugget of some of the other issues yet. I'm really glad you raised that. Thank you so much, Dr. Renu.
And I think also there's a couple of colleagues of mine who are looking very strongly in obstetric violence, where healthcare providers the women's experiences of healthcare and institutional births constitutes violence, and calling that out, maintaining other programs of support, even if it's in institutional supports with midwives and doulas. And, the mother does not exist at the expense, or the baby's not at the expense of the mother, although, the other way around, the mothers are not expendable. And it's just criminal to see how women are treated in the system.
May I add something? Thank you so much this is Dr. Susan Minnick. I am just really impressed with all that you've presented, and I've seen you present before through Healthy Seminars. And I've been a nurse midwife for many years, 42 years, and I'm very passionate about delivering in the hospital and teaching the doctors how to deliver babies and not to have all that fear around the birth. And it's awful that this whole thing has swung back to the fear-based medicine. Like you said, you can't do a medical intervention without having a consequence or something happening. And the postpartum depression, the violence against women, the midwives where I work, we work for Kaiser Permanente, a big HMO in California. We are working on violence against women for birth. And we're putting a program to present to the doctors about how you treat women. Do you examine a woman? You just don't shove your hand in to do a pelvic exam. You don't, be rough with a breast exam. Many women are sexually abused, and you have to be really careful how you see them and treat them. I just had a patient, I'll say this really quickly, that it brought to my attention. I saw her the whole pregnancy, so connected with her acupuncture, getting ready to deliver the baby. The baby was breech. We planned for a beautiful C-section. She broke her water in the middle of the night, came in to labor. The doctors had no clue who she was. They laid her on the table, strapped her hands down. She went into trauma when she was sexually abused. We never knew. We had no clue, but that birth triggered her sexual abuse when she was a child. And that's all I'll say. I don't want to take your thunder away, but there's so much out there. And I'm very passionate about that, like you. And thank you again. And hello to everybody around the world. It's very nice to see everybody. So sorry if I'm talking too much, but
thank you for your
Susan.
Kate, you answered this in the chat, but just for everyone else to hear, Christine had asked, what is the time frame expected for the prospective meta-analysis? Do groups need to be randomized, or are groups self-selected?
Okay, thanks. Great question. If you're planning to do a study or you'd like to do a study, there's no time frame. So all you need to do is get funding to do your own study. So if you've got funding and you can run a study, then that's all we need. We've got enough data now. We've got enough projects now that we can start the prospective meta-analysis, but it continues on. So as long as people are doing programs, you can add the data to that prospective meta-analysis. You ordinarily, to start with, we thought that only randomized controlled trials would be able to be included. But given what's happened in COVID and things have changed a bit, we've decided or consulted with the statisticians about how we can add cohort data. So cohort data is just like a group who go through a program who have no control. So that is also a possibility, but there's a team that we can discuss all of those possibilities. We've got some great statisticians and epidemiologists on board.
Sometimes I used to work as a doula for many years. Sorry, I'm just jumping in.
Please.
I used to work as a doula for like 8 years. I did acupuncture in labor and worked as a doula, went to labors. And, you spend a lot of time helping women get educated. You feel like they feel very empowered. And I feel like sometimes all that information is lost depending on who the healthcare provider is when they walk into labor. And I sort of feel, I go to these talks and I hear all this, like your presentation was excellent and all this information. And I'm like, how do we get it to, like, I always feel like if it's the wrong care provider who meets them at the hospital, if they, like that woman who went into labor when she didn't plan on it, everything you did just goes out the window and even I as a doula, armed with information I sometimes had to, I didn't have any say once I'd gone to the hospital if it was one care provider. And so I just wonder, how do we get this information to the people that really are the ones like it's like that, like the disconnect between, it's not all doctors, it's not all midwives certainly, but there's just so many. I don't know. That was always a frustration I had as a doula.
That is my primary frustration too. It just goes out the window because there's no integration. And so what I think needs to happen is that it's made into policy. So if it's not in the policy of the hospital, things don't happen. And so when something is made into policy, we've got all this evidence. And also a couple of students of mine are doing a guideline review at the moment, looking at all the guidelines across Australia, all the state guidelines. Nothing. There is no mention of childbirth education beyond attend at 17 weeks or whatever. No mention. So this is what my kind of fight is about. Make it into policy. And then it has to start being practiced. But it's like you've got to legislate before anyone will do anything about it. There's no integration. And my PhD student is doing her study she's using the Bowen family systems therapy approach to looking at how care providers, partners and women, how they lose their voice or how they gain their voice depending on who else is there. So she's looking at the relationship aspects of the care provider, partner, and herself, and why people might lose their voice in those moments. It's like they've done some studies here in mental health units, in the psychiatric units, and if the manager is seen to have a high stress component, it filters down and all the kids on the ward are more medicated. So how does stress filter down to higher medication rates for children in that particular study? So we're looking at how does stress in the system filter down to higher intervention rates in the hospital system. So I think that's going to be a key piece of the puzzle. But it is so frustrating.
But that, if I may just say, Dr. Levett, that raises the burnout issues that we're facing all over the world right now, all throughout the healthcare systems. I see that as a massive, massive concern, that healthcare systems are collapsing under the weight of burnout of our healthcare providers, and the pandemic exacerbated pre-existing tensions. And so a stressed out manager in a maternity ward, resulting in higher intervention rates for medications for patients, is a result of a systemic failure to take care of our healthcare providers' mental health needs, reduce their stress, and overall systemic issues that are related to patriarchy and not dealing well with women healthcare providers. Violence against healthcare providers is another issue. We've talked about violence against birthing women and traumas that are undisclosed or haven't been followed through because there's a lack of continuity of care. We have I think you briefly mentioned violence by healthcare providers of birthing women. That certainly is a very under-discussed issue, that sometimes midwives, physicians, and nurses beat women, particularly women from working class and marginalized communities. And then there's violence against nurses and midwives. So there's violence that permeates the healthcare system, which is such a serious and undiscussed issue, and very much related to the reality of women being dominated in global society still. So we have so many issues that we're unearthing here in these conversations. I know we've come to close to our time. We often do just run over a little bit because this is where the rich conversation happens. So Dr. Levett, with your permission, we could continue. And I think Lori wanted to say something. So please go ahead. Lori, please go ahead and say whatever you would like to say, my friend.
Hi, thank you so much. I think you just eloquently very much said all that we're feeling as practitioners who are helping. I treat fertility and pregnancy and postpartum. So I see these women all along the way, and many of them are already in IVF clinics, which there's so much happening there, even pre-pregnancy, that isn't recognized or called out. And it really does come down to education with those patients and their partners. And I just really appreciated everything you had to say, because I do think that so many of these issues aren't really being discussed. And the way that we see violence, if it's not someone being hit, for some reason, we just think maybe it's not violent, but it actually can be an interaction that is violating. So I just really appreciated all you had to say.
Yeah, I'd love to see doctors and midwives have their education altered, and the system. I mean, I think the system needs to scrap what's going on and start again. The system's terrible, and it's just been patched together in a way that doesn't address or suit the current needs. And it would be great to see a reinvention of our healthcare system, because you can see all the doctors, nurses, everyone is crumbling under the weight of this. Everybody.
Yes.
And how do we support doctors, obstetricians, midwives, nurses, all of those people to be compassionate carers when nobody's compassionate to them?
I love that whole point about redesigning the system, because we absolutely need to do that. And midwifery care in Canada has been seen as one of the most important professional attempts at trying to make healthcare women-centered. It's always been called women-centered care. Of course, now we talk about pregnant people, so pregnant people-centered. But But the rest of the system, like when I put my book out called the New Midwifery, Reflections on Renaissance and Regulation, it was all about the promise of regulated midwifery changing childbirth practice and thereby creating ripple effects for the rest of the healthcare system. So that if midwives could have a practice that was truly patient-centered, that doctors, nurses, and specialists could also follow suit. We know that many naturopaths and many traditional Chinese medical doctors and herbalists are really good at patient-centered practice, but we haven't seen as much of this filter into hospital systems. So I think we're seeing more crisis right now than anything else. But my feeling is that in the time of a crisis is the time to start creating, like you said, Dr. Levett, this is the time to start saying, well, if it's not working, let's start from scratch. Let's create a truly patient-centered system. And we can do that. This is our moment. Let's seize it.
Yeah, agreed. And I think it's in the training. Our government's is about to put out a budget about the recruitment and training of a whole, like 100,000 midwives and nurses and people to support the system. But if they just keep training them in the same way, the same thing's going to happen. There's an average lifespan of about 5 years of a nurse or midwife. So having a new way to address education and care and support for new grad midwives, for student midwives, think that coming back to grassroots, how do we educate and support those new nurses and midwives?
Yeah, I think that's a wonderful place to leave it. Looking at creating better education for a new kind of workforce that can really bring about our new generation, that can raise babies into the world, bring babies into the world in a beautiful, loving, and kind way, is a wonderful way to leave it. I don't see any other questions. I would like to thank Dr. Levett very much for your work in general, for this presentation today, and to each and every one of you for joining us from so many places in the world, and for all your work that all of you are doing to provide the opportunity for mothers to raise the next generation in a way that is loving and kind and centered on their emotional, physical, mental, and spiritual needs. Thank you to all of you. And once again, we do really, really welcome you to join us for other webinars that we're having. I've put the MIHCancares@gmail.com email there. Please just email us. We'll get you on the list, and we'd love to continue dialoguing with you. We do education, research, and innovation. And so there's all kinds of collaboration opportunities. So with that, I would like to say thank you and be well.
Thank you so much for the opportunity to speak.
Thank you.
Bye, everyone.
Thank you. Bye-bye.